I was about 7 or 8 at that time, and I'll never forget there was a young kid that was a little bit older than me, and we were at a marketplace, and he had come up to my parents and I, and he was asking for some extra funds to make it to a hospital with his mother.
Wow.
But the thing that was really significant was that he, was definitely dressed, and probably the only thing that he had. He looked like me. He looked like I could easily have done the same thing if I was in his position. I remember asking my dad, what was it exactly? Why can't he get the care that I could at my pediatrician, for example, right? So it started stemming a lot of questions about how things look different in different places in the world. That's kind of how it catapulted me to look more into how I could be a part of the bigger picture for other people.
In this episode, we're going to chat with Dr. Mo. We're going to talk about her passions, specifically also walk with a doc and how she got involved and what it took for her to become a medical doctor in Dallas. Let's go with Dr. Mo. Let's get right into it.
Let's do it.
How's your day going? How's your week going?
Good, yeah, not too shabby. I always love my Fridays because I can kind of reset a bit and get to do things like this.
That's awesome. Thanks for coming on. Middle of the day. It's pretty sweet.
No problem. Thanks for having me.
So Dr. Mo, just tell us about yourself in general. What got you into medicine?
Well, so I'm from Dallas, and I initially got into, I would say medicine when I was 7 or 8 years old. I've always wanted to be a doctor. So that typical kind of saying of, how did you know? I don't know. I think my pediatrician really impacted me a lot when I was growing up. And seeing a female physician in particular, I think was really impactful. But my family, we would travel a lot, doing lots of family vacations. And one particular vacation, we went to Jamaica and, got to see all the sights, Bob Marley. Hey. It was great. But I was about 7 or 8 at that time, and I'll never forget there was a young kid that was a little bit older than me. And we were at a marketplace, and he had come up to my parents and I, and he was asking for some extra funds to make it to a hospital with his mother. But the thing that was really significant was that he, was definitely dressed and probably the only thing that he had. You could tell that he was just trying his best to try to make a way for him and his mom, barefoot in these streets that were definitely unpaved. And, he looked like me. He looked like I could easily have done the same thing if I was in his position. So I had a lot of questions after that. And I remember asking my dad, what was it exactly? Why can't he get the care that I could at my pediatrician, for example, right? So it started stemming a lot of questions about how things look different in different places in the world. And that's kind of how it catapulted me to look more into how I could be a part of the bigger picture for other people. And so, I just, science was my main thing. Yep. And, in high school, just, did all kinds of programs in the summer. Had like a Texas Women's University camp I went to when I was like in middle school. Yeah, it was a forensics camp though. But so I did, it was a forensics camp. We had to do all kinds of stuff like
cadavers?
No cadavers. We were too young for that. But we were like looking at different cases, back in the day with the John Benet Ramsey case, and so just different things. And it was really good to kind of think outside the box. So even though I was envisioning, of course, in the future I want to work with patients, kind of like my pediatrician, it was really neat to have those type of experiences too. And I eventually had to have those experiences in medical school. So and it kind of got me to where I am today when I think back at that initial experience in Jamaica and then looking where I've come from in terms of my medical journey, being abroad and doing work abroad. It's really interesting how full circle it is.
Wow. And that's that really catapulted you through everything.
It did, yeah.
Well, you remember those long nights studying, like did that residency, all that?
Goodness, yes. Or those calls, like I still cringe when I hear a beeper go off. I don't even know if most people know what a beeper is.
Probably not. Or they have like the cell phone that like sounds like a beeper, the ringtone, or something like that.
I'm telling you, it's just not good. But those experiences at the same time, I'm like, I did that though. Undergoing like those types of challenges, I think we kind of get lost in sometimes the day-to-day, but when we recognize the why behind why we're doing what we're doing,
100%.
it makes it all worth it.
Yeah. Wow.
So I do remember those nights though.
Oh my God.
Yes.
Wow. So going from graduating medical school, what was that next step? How did you know where you wanted to practice? Because there's so many different things you could do.
Yeah.
What kind of guided you to where you are right now?
That's a good question. So, I mean, graduating, I feel like, you know, the ball's in your court, right?
Yeah,
and so having those mentorships was really important to me. I knew that at the end of the day, because of the way that I trained, I really wanted to be able to be involved in the community in some way. So I was fortunate to have a lot of those mentors to kind of guide me along the way. But until I could really like sink my feet into a role, I did some urgent care work. Working at, you know, some clinics here and there, and that was an experience in and of itself. Being able to triage a person, see, you know, the acute need, and make an instantaneous decision. You can't like really learn that unless you're in it, and if you're in it every single day. But it wasn't for me, and I decided, you know, I do want to try to find something that I can get to know a patient and hopefully their entire family in a different type of setting. So that's why I think when I came across like various clinics I've worked at, it ended up being a better fit at the end of the day. So family medicine, because you're seeing more of from infancy all the way to you know, geriatric age or elderly population, you have to know a little about everything. And so, you know, urgent care comes in the mix of that too. So being able to see, okay, this person really should probably go to the hospital versus feeling confident that I think I can really treat this myself and avoid a hospitalization. So yeah, I think that it led in terms of me being able to have those experiences to where I am now, which is more focused on geriatric care. I never really envisioned I'm going to be working in this population for as long as I have so far. But I think it kind of reflects back to my grandparents. I grew up with my grandparents and seeing them go to the doctor and just, you know, recognizing certain things about the way they interacted with their physician also instilled qualities within my own self. For example, even my grandmother, she has an oncologist that she had been with for, gosh, I think almost 20 years. And that oncologist treated actually my grandfather before he passed away. But what's really insane is that full circle, now he has seen me grow up, and you know, since I was a kid. And it's funny because the way that he approached healthcare and the way that he respected and valued my grandparents really stuck with me. I was always like, you know what, I want to be like them. You know, and so I think those types of experiences, it's little by little, but it does shape who you are.
It does, it's like the experiences that you've seen from just life in general really pulls you to be the best doctor that you could be.
For sure.
So if you had someone who was just like basically coming out of medical school and looking about going into family medicine, just in general, you know, the books teach you certain things. But what would you if you had any advice for someone, like what were some things that you have learned that can really help them do a good job? Just curious.
I would say, you know, it's always good. Number one, you want to go into it for the right reasons. I feel like sometimes there may be hidden pressures. I've heard from other friends and, you know, colleagues that they may not have had that intentionality in the beginning, but then came to fall in love with it, which is great. That's a positive outcome. But then you may have the other outcome where if they do happen to get more forced or pressured for societal purposes, families, you know, anything, then they're not going to have as much empathy for the patients they treat, and then that will also dictate how patients do and their outcomes. So I would say make sure you're doing it for the right reasons and find your why. So why do you want to be a physician? What makes you so passionate about the work of what we do day to day? And try to work alongside a physician and be authentic and what you want to see. Because if you want to see everything, you can, but you have to be open to the reception that not everything is, you know, rainbows and sunshine, and that's okay. That's within anything you do. But it is important to really see what it means to truly be a physician. It's not just wearing a white coat. It's not just walking in and writing a prescription. It's more getting to know very authentically and genuinely what the needs of this individual are and how you can collaborate with them on trying to make their lives better. And so I think that that's really important for our generation and those that go on after us to know intentionality is important. And so being able to go into it with that mind is important. And there are going to be challenges. I mean, I did not do great on the MCAT the first go around. And so, you know, you have to keep going. And I tried again and knew that at the end of the day, this is what I'm set to do. Surrounding yourself with good people that can encourage you and your dreams is also very important.
That's massive. I think like the biggest thing is, you know, we serve seniors, right? And so like that, the next generation of doctors, of healthcare practitioners is massive. And they've got, I like what you said, they've got to have that heart. They've got to have the desire, because it's a need.
It is.
And it's going to tax you.
Oh yeah, it is. It is. And you have to find a way to fill your cup again. And because I think that's sometimes where you have that burnout and physicians may get deterred to just quit. And you have to just kind of go back, like I said, to that why. It's not about the accolades. It's not about, like I said, the superficial things. You have to really want to help people.
Okay, so let's talk about, how do you fill your cup? So how do you like refresh, you know, in the midst of a crazy work week, or as a doctor? Just some tips you're using.
Exercise is great, so definitely.
Let's talk about walk with the doctor a little bit.
That's a good transition. But I think, you know, me and my husband actually have a personal trainer, so shout out to our personal trainer. So we do try to work out a few times a week and then get some walking in. I walk with the doc is a great, you know, kind of caveat, you know, to that. So with Walk with the Doc, it is a program that I've been a part of now for the last 5.5 years, and so once a month I actually will host a walk at White Rock Lake, and anybody is welcome. We'll talk about a health topic and then we'll walk a little bit. And I think it's great to be in community with other people that are also trying to better themselves. So sometimes we get kind of stuck in the four walls of a clinic. That's the only way you can see your physician. So this is an opportunity outside of the four walls to be able to break down any kind of, you know, barriers, so that patients can speak to you, you know, very, you know, transparently about the struggles that they're going through. Also, family, friends, they can ask questions, things that they're dealing with or don't know how to quite approach with their own primary care provider. And it just opens up a lot of opportunities. So I love it. There's ways in which people can get involved, whether you're a medical student, physical therapy students do it too. It's also international now. There's various countries that are now taking on Walk with the Doc. It's pretty cool. And so I really love doing it. It takes like a little bit of a break from my normal day-to-day. And now I'm implementing it more even on a more local level where my clinic is located, to try to get our seniors more active and kind of accommodate their needs instead of maybe walking outside, because we know this Texas heat is, you know, very difficult. We were just talking about that. Yes. So, you know, doing it at a rec center, doing it at a local gym, things like that, that other people can get involved that may have various levels of abilities. So, it's a great program.
It's amazing. How did you get involved with like walking the doc, or walk a doc? Sorry.
Walk with the doc.
Walk with the doc.
Cool. I was actually told about it through, I'm a part of a few different organized medicine groups. One is called the Texas Academy of Family Physicians. And so I was a part of a program that I guess as a part of the culmination of the program, had to do a project and what we wanted to do to give back to the community. And so Walk with the Doc was something that I heard like a buzz about, and I said, let me learn more, and that's when I started. So it was kind of a project that I took on to see how it would work in my community, and then it just catapulted, and I said, well, I'm just going to continue it, and now I've done it for 5.5 years. So it's really fun. It definitely breaks up some of the, you know, day-to-day, as I mentioned, and it gives back to the community in many ways. And I feel like patients are more apt to attend because they know, okay, there are going to be other people there that may have same questions as I do, or different questions, and it just breaks down those walls, like I said.
That's cool. That's cool. Hey, if you haven't already, make sure you like and subscribe. The YouTube algorithm told us, what they tell us? It told us it was like 99% of our people watching these videos are not subscribed. So that means you need to subscribe, and hope you continue to enjoy our content. All right, bye. That's cool. So let's circle back to you as a doctor, right? In terms of family medicine. So you mentioned you serve more seniors, right? Or geriatric populations, kind of mostly. So let's walk behind the scenes of what you do in a day. Like I know you see patients, and sometimes patients know Dr. Mo, right? But what does your day-to-day look like? What do your rhythms look like when you're in the clinic or at the office? Just curious.
So usually my day starts off with a pre-preparation. So I'll know the patients that are coming into the office. I'll look with my team, which consists of a medical assistant, and I actually have the opportunity and privilege of having a scribe.
Oh, nice.
So a medical scribe also is a huge win in many ways because you have that ability to teach the scribe kind of what you're looking for in terms of a note, what to include, what are kind of your diagnostic approaches. And a lot of our scribes tend to go on to various roles within medicine. So that's kind of a nice teaching opportunity. Once we kind of gather together as a group, we'll discuss what we want to achieve out of every visit. And sometimes what we may think will happen doesn't happen. So sometimes we may have, a patient that comes in and unfortunately they had a loved one pass away, and that's the focus of the visit. We're not going to change anything else around to try to meet any kind of metric. I think at the end of the day, patients are seen as people. Some people, I feel like, can feel as if a clinic is more of churn and burn. Let's just get them in and out. But what I love about the dynamics of the way we approach medicine in our clinic is that it is very holistic, and seeing the patient as, they're coming as they are, and what can we do to help them get through. So we have a plan, but it doesn't sometimes go according to plan. But I think that pre-prep is very important, and it sets us up for success for the day. So what vaccines do we have? What vaccines do we not have? Are there medical equipment items that we actually have in center that we could give to this patient? What are the DME needs, right? Home health. Are there things that we need to be thinking long term about this patient? So all those conversations go on for about 40 minutes at the beginning of the day, and then off to the races, and we're seeing patients. Now, in between that time, I may be called upon to, do a medication reconciliation or look over medications to send in for a patient to a pharmacy. There may be other kind of different tasks, so you're balancing a lot. But I think at the end of the day, what we always like to do is just go back to the fact that, okay, we're trying to set up a patient so that by the time they leave the clinic, they're not leaving more confused, but they're leaving more empowered. So sometimes, you have to just make sure you have a lot of things on your agenda, but at the end of the day, even if you don't get through all those things, you're trying to make sure that particular goal is set. Someone's leaving feeling more confident in what they have going on with their health. So as I go through my patients, kind of wrapping up through the end of the day, I may have additional type of administrative tasks that I have to do. But at the end, that's pretty much it. I try not to take any work home. And it's very difficult to do that, but that balance is important.
That's true. That's true. Wow. When you see a patient, during that day, how often in a year, just how frequently do you see a patient, if you were to say, Miss Betty comes to see you? Normal, right? Just a normal, normal needs.
Sure.
How frequently do you see them in a given year?
In a given year, so I would say at least on a minimum amount 4 times a year. That's minimum. We have, different systems of how we, do the cadence of our visits. So there may be a patient that has a lot of needs, and so we're going to see them every 3 weeks. Maybe even sooner than that, depending on what's going on. Because I also happen to see more Spanish speakers, there may be also more time allotted for me to be able to take time to do medication reconciliations, make sure that they understand the medicines that they're taking. I think sometimes because in other clinical settings there's shorter visits, you miss a lot. And so we try our best. We can't do it all, but we can do better than the last time, right? And so there are some things that we'll note on the chart, like, I don't know if this particular patient, for example, is completely literate. Or I don't know if this person may understand the different medicines they're taking and the why behind it. So I always try to make sure that patients feel empowered of why they're taking certain medicines. If they have questions about it, to be open with me about why they may be hesitant about taking something. Because a lot of times, if you just don't ask, you're not going to know. I always tell patients, I don't know what I don't know. So if you don't tell me,
I don't know.
I don't know. So, but yeah, I think that usually the cadence is like minimum every 3 months, as early as every 3 weeks.
That's cool.
And so in between that, 1 to 2 months.
Wow.
So yeah.
That's awesome. What do you do as a doctor to kind of keep those rhythms in between? So in between those 4 times a year, how do you check up on them? What are some things that doctors do?
So within our practice, we have so many people that are hands-on. So we have people that happen to look at statistically kind of the cadence of patients coming in. There's also ways in our EMR that we're able to see, okay, this person hasn't come in for X amount of months. Let's make sure to flag them so that they can come back in.
Gotcha.
We have community health workers. We have a social worker. And so those types of individuals that are so good at what they do, they're instrumental in being able to keep patients in. And our outreach team too, right? So we have our outreach individuals, so they will also have kind of their own lists of patients, so to speak, to be able to keep up, let's say, with Dr. Mo's panel and what's going on there. So we are able to meet that need in those ways where it's not all on the provider. It's kind of distributed amongst the team.
That's
exactly.
Really cool.
Yeah.
Wow. So let's walk through just normal diagnoses that you see a lot, you know. So I know a lot of times when someone talks about hypertension, it's like, oh, right, or just, you know, diabetes. What are some things that you see common, and then what are some things that you can kind of advise patients when they look at these things, when they see these things?
So I would say for hypertension, so I always break it down, like, what does that mean to you? So blood pressure, okay, we can kind of break it down with that. A lot of people don't realize how silent blood pressure is. Some people feel like it has to be only symptoms. So I have to have a headache, or I have to have chest pain, and kind of those more alarming symptoms, when you don't have to have any of that to have high blood pressure. So I always educate first about, okay, what's your family history look like? Have you been told you've had high blood pressure before? We'll talk about symptoms too, but also looking at their diet and trying to kind of go back to basics with that. A lot of people, again, they're just not aware that certain things that they may be doing day to day are detrimental to their health. So I don't assume that they're just intentionally doing certain things. You have to ask, and also knowing where they live, what their access is, and are they even able to afford certain medications? Because they may have been prescribed medicines in the past, let's say by another provider, but they didn't take them, not because they were, you know, intentionally trying to be non-compliant, but they just didn't know why they were even taking it in the beginning. So I always bring up diagrams and photos. I'm a very visual person, so I'll always, bring up a picture of a heart, for example, or when I'm talking about something like peripheral vascular disease, which is related to hypertension, I'll show them, like, this is what's going on with the circulation and the blood flow. I use kind of different descriptors or analogies, like a water hose, like, okay, you're watering your yard, and you know how water's going through? Well, what if Mr. Charles wasn't so nice and was behind me and kinked the hose? That's not good blood flow. And so that can happen in the heart. So I feel that we have to kind of get back to the basics. I'll explain to them what that means. Hypertension really can mean different things for different people with different conditions. So your goal blood pressure is going to look a lot different for someone that has diabetes. And same thing for anyone, let's say, with chronic kidney disease. And your age matters too. There's different thresholds. So I try not to get so nitty gritty until, like, we start getting into issues where it comes to control, so that they know and they feel empowered. When I go home and I check my blood pressure, I know if it's more than 140 on that top number that Dr. Mohammed said, and if it's more than, let's say, 100 on that bottom number, I need to call her. You know, so I try to empower them of the why behind that, use those descriptors like diagrams so that they can better understand. And then when it comes to, I feel like, the food and making sure that they're eating properly, I usually will give, with the help of my medical assistant and scribe, information, for example, like a grocery list. This is a good diabetic grocery list. This is a good anti-hypertension list, for example, to go off of. But also understanding what grocery stores are nearby. Are you in a food desert based off of your zip code? Are you running out of food at the end of the month? And so that's when we can kind of tag on some of our other folks within the clinic. So whether it's a social worker, community health worker, or even me, now that I'm out in the community more, to be able to say, hey, there's a food pantry near you.
There's an Aldi's right there.
Yeah. Stuff like that, I think, goes leaps and bounds where patients feel more comfortable sharing with you, because I think sometimes they'll go in thinking, are you going to get mad at me? We're kind of seen as like such a big, like we're going to reprimand them.
You got like a ruler in your back pocket.
Yes, exactly. And I'm like, no, I'm not here. I'm here to help you. I want to be seen as kind of your partner in crime, not someone that's going to like lock you up, And so I think that kind of disarms things a bit more, and then they're honest. And when we check that blood sugar, that A1C, every 3 months, which we do to check the blood sugar, if it's higher than normal, usually before it even comes back, the result, someone will tell me, I ate a lot of cookies this weekend, or, over the last few months, or, holidays, and I know I'm going to get better. And then they'll feel empowered to set their own goals. They're not achieving it for me, they're achieving it for themselves. So, I think those type of tools are really helpful. I like visuals. I like patients leaving with items that they feel like they are empowered to use, so that when they do come back, they can tell me what they've done.
So you said hemoglobin A1C. Let's see if someone doesn't even know what that is.
Yes.
What is that?
Yeah, so it's, okay, that's a great example. So our blood cells, our red blood cells, will carry on glucose, and that is an average. The A1C is a measure of those red blood cells on a 3-month or so average, how much glucose is attached to those red blood cells. And so an A1C, we usually will hope no one meets a threshold where it goes into a diabetic range. So an A1C of 5.7 or below is actually, what we would say is a normal blood sugar, but 5.7 and above, like to about 6.4, is what we call borderline diabetes. Anything above 6.4 is what we would say, like 6.5 or higher, is diabetic. So we do want to measure that every 3 months, because it gives a good indication as to someone's eating habits and what they're kind of doing in those 3 months to help achieve those goals. But that being said, A1C is not perfect, and so there are certain things that we have to keep in mind, like someone that may be a dialysis patient, their blood sugar may be a little bit altered, not a significant amount, but it's not an exact science with that because of their medical conditions. So it is a really great tool to use, but I always tell patients, because they think that what they've done that day or the day before is an indication as their A1C, and I'm like, but no, that's actually 3 months.
3 months in the work.
3 months. So, but that's what A1C is. It's a great monitor of how someone's doing. And when we talk about our elderly kind of geriatric age patients, we also don't want to be insanely aggressive, because we may have targets for those that are under, let's say, 64. Usually an A1C below 8 will help achieve a lot of goals, like better vision, less neuropathy, which is like tingling sensation in the fingers and the toes and stuff, overall better health with the kidneys. So all those things, it's like a benefit if someone can drop their A1C half a point or even a point. All those things are so much, I guess, like meaningful if you're explaining to patients that because you've achieved X, Y, and Z, you're minimizing your risk of a heart attack, eye disease, all these different things. So it's a big win. That's a really good, I guess, talking point a lot for patients.
A good start, almost like a baseline, or is it?
Yeah, a baseline. I've actually diagnosed patients, them not knowing at all, where they've just been having symptoms of, let's say, increased urination, lethargy, dry mouth, and just feeling fatigued. And, family history may be possible that they've been diabetics, and when I check the A1C, it's full-blown diabetes. And there's, of course, kind of that deep breath in the room, but also a sigh of relief, because they didn't know. And so now we can have a means of detecting further things that could go wrong if we don't go ahead and address the diabetes, but also making sure that it doesn't progress to something way worse. So
that's good. I know that's so important. I think it's good, because I think a lot of times people just need to know where to start. Sometimes, like, do I focus on this, or like talk to their doc about this?
Yes,
so that's really good.
Screening is important. So family medicine, we're always seen as the screeners and preventers. So that's why it's so important to have a family physician because we're able to see based off of your age, based off of your family history, risk factors, and of course having blood work to complement that. But we're able to see what could be and try our best to prevent those things from happening. I've had patients, for example, say, "Oh, but I don't want a mammogram," and I'm like, "Well, why?" You know, asking them why, listening to them. What is it about having X, Y, and Z tests done that you're afraid of? And then you end up uncovering, "Oh, well, it was not it wasn't a comfortable test," or "I was afraid because I may have cancer because my mom or dad or my mom or family member ended up having cancer." So finding out the why behind it is also important, and then we're able to prevent so much from happening. I always tell people we're not God, okay? Like the God complex, no, we're learning too. So I think again that disarming mentality is so important.
And I love the fact that I think the biggest thing is the time to take with the patient. I think a lot of times, in healthcare, just sometimes the way it is with doctors, sometimes you don't have that much time. But like the fact that you're able to take time, teach, walk the patient through, these are the signs and symptoms, these are the treatment plan. I think it helps overall with outcomes. Would you say as well?
It does, and I'm a big proponent of repeating. So I want the patient before they leave, you tell me what I said. What did you hear? Because sometimes quiz them at the end, like, okay, so you're taking this. Yes. And I always have them bring their medicines every visit, not just like once every couple months, but getting them in the habit, because you end up finding out things like, oh wait, you ended up getting 2 refills from the pharmacy, but you're actually taking both medicines. So that's why your blood pressure is low and you're not feeling so great. Something really small
can have a big issue down the road.
Certainly. So yes, I think that teach back method is super important, and just being able to have that time, as you mentioned, is very critical. A lot of the former practices that I was in, we didn't have that, and so for me personally, I didn't feel like I was doing as good of a job being a clinician because I had to kind of get in and out, but I still took as much time as I possibly could, but you could tell that it just a little bit more time would go that extra mile for that patient. So it is very, very meaningful. It helps prevent hospitalizations 100%. As well, and having family members join too. I think that's important. I always try to have like a family member come in for a visit if they can, just so that is also someone's counterpart to be able to reinforce what maybe I've said during a visit in case the individual may forget.
Keep them accountable. Say, hey, Dr. Mo said this. You remember that? That helps them actually get better. Well, that's cool. So now we talked about hypertension. Talked about a little bit about diabetes. What are some other common diagnoses? You talk about depression. What are some other things that you see, and how do you help patients go through that?
Sure. Depression, I think depression, anxiety, dementia, I think all of those are very critical and important no matter who you're talking about. I think sometimes it can be very much overlooked. And so I think it's important that the whole clinical team feels comfortable with talking about it, because oftentimes it may be a medical assistant that's screening for these things, and they actually end up finding out, and they may not know how to bring it up to the provider, but also they may screen fine and actually seem like, okay, no depression, no anxiety.
It's zeros on everything.
And then you go in
flat affect.
Something's going on. So I do feel that that's also really important. I think being able to encourage patients to be able to express themselves and what they're going through, because there's seasons in life. And so it's important for them to be able to come to you no matter what and have that trust to be able to say, you know what, I'm not feeling that great and this is why. Or I may need help, because things can still be so stigmatized in various settings and various cultures and even amongst family that they may not feel that it's okay to talk about these things. But if they feel safe to talk about it with you, you've
really
won.
good.
That's power to be able to help that person.
Wow.
And so, yes, I feel like the whole clinical team being able to be very informed about certain things, what they look like. I would say for depression and anxiety, what we definitely do is if someone does happen to screen high, or they don't, we will make sure that they get tagged up with a behavioral health specialist.
That's cool.
And also connecting somewhere within the community, pending their resources with insurance and things like that, but with extra counseling and behavioral therapy. And I think that that's really important. And sometimes when it comes to things like high blood pressure, or we're talking about diabetes, those conditions that are sometimes overlooked can actually improve those other conditions, right?
That's very true,
because stress, anxiety,
think straight.
you can't think straight.
Can't follow, you can't follow the plan of care that you may have.
Right. So, we can be focused in on compliance and why, but if the person's depressed, if they can't think straight, you're just going to be in a cycle, right?
Wow.
Dementia is also a big one, I will say. I think that's why I always will try in my practice to bring a family member into a visit, and also making sure things like advanced care planning, medical power of attorney, those items are done within the first visit or the first few visits, because the trajectory in anyone's life as we get older, there are going to be things that change with our cognitive abilities. Doesn't mean obviously someone's going to get dementia, but there may be challenges that you're not able to foresee. So to kind of prevent those things from happening in the future, where you're not sure who the person may be within their circle that they trust the most, or that they have the most confident in helping them make medical decisions, having those conversations more early on is very important. I think it's very important also to understand someone's background, whether it's their literacy or lack thereof level, education. All those things come into play when we talk about cognition. And so I'm a big proponent of making sure to do those mini cogs. Those are assessments for your cognition, and seeing how patients track throughout the year. We may do it once every 6 months just to kind of compare notes and see if there's been any changes going on, or talk to the patient themselves. And sometimes they'll bring it to you and say, not only have I forgotten my keys, but I've forgotten where my car was and everything. And so we can really try to dig deeper into that.
What do you advise family members who they have like an uncle or an aunt or even a mom or dad who's struggling with, you're seeing signs of dementia, and like what do they do when they're kind of like in that place and they're like not willing to like maybe go to the doctor? Like what do you see?
So safety is number one, right? So I would always try to see if it's possible, make sure those individuals are not alone for extended periods of time, checking on like locks on doors. If they feel like there may not be like a safe method of them, like let's say driving or doing things as independently, then that's when you probably should be able to, try to find and contact a healthcare provider, because that's something you don't want to happen where you wish you would have gotten help sooner. But I think destigmatizing it is important. For some, different cultures and members of society, they feel that if for any reason an individual is diagnosed with something like cognitive impairment or dementia, then that means their life is over. And there's so many layers to a medical diagnosis with that. But I always encourage people, it's important to have someone like a family doctor that's already in the patient's life so that those screenings can be done and the whole family can be involved. I think it gets scary when you just are not able to have that support. And there are groups out there. The Alzheimer's Association is one of the best groups out there, and they have all kinds of support groups. They have different, means of like presenting to patients and their families different signs and symptoms to look out for and support along the way. And a lot of it's free services, which is really great for some individuals that may have financial constraints. So
that's really good. That's really so they don't feel like they're alone.
Yes,
I love that. Like utilizing other resources to say like, okay, you're not alone in this journey with mom and dad or aunt and uncle. That's really good.
Exactly.
That's really cool. What as we kind of bring it back full circle, that impact that you had when you were in Jamaica, right? And how you were able to see, that young boy. Like, how are you now applying? Like, you're a doctor. It's crazy. Like, you're a doctor now. How are you applying giving back in the community? What are some things that you do to kind of be fulfilled as a doctor?
I think being able to go into communities that are so overlooked. I think during COVID especially, that was unmasked in so many ways, where a lot of our underserved population was even more forgotten, but it also created a lens for people to see, oh, what are we not doing? You know? But for me, I think it's always been that giving back, like even from early on in my, training in Dominica, through my medical school to even and throughout Parkland and UT Southwestern as well with the training, we're able to really give back to our communities. I think that it helped create a different type of lens that I see medicine through. So we have the luxury in the United States, right? We can order any test. We can do X, Y, and Z. But if we're not able to do like bare, just physical examinations, basic things, then we've kind of lost our touch. So I'm always trying to better myself, but just going back to the basics and seeing the need. This person may not need a CT scan or a chest x-ray right away, but let's see kind of what's going on first, because there may be financial constraints. Insurance is probably not going to cover that. There's all those other extra layers of thinking that I really believe that through my experience of being abroad really helps shape how I approach
most
things.
Pressing need.
Most pressing need. And also how to do without. There may be some things that we just can't do, and we have to figure it out. I've had many things like in the past where I created an ICU from not having much at all, abroad, and the patient did well, and it's like these things through the help of many other people. But those types of things and being in those challenging situations really push you to be a better doctor, so that you can take things back home, which there are things that are happening stateside and very much domestic type of situations that you can do better. You don't necessarily have to just write that order right away, because you have to see what that after effect would be for the patient. They may have a $150 bill that they just can't pay. So if it's needed, okay, but it may not be really needed. So I think that really has helped shape kind of my approach into my diagnoses and my treatment plan. It's really a good, I think, asset to be able to see how medicine is practiced in other settings, right? And it's challenging. It's definitely challenging, but I think it definitely helps, kind of shape you.
I think it's powerful, because I think when we really look at what healthcare was meant for, it's meant for care. And I think a lot of times, just organizations in general, they forget, okay, if there's a boundary to care for someone, you have to create the ability to care for them. And a lot of times, that's what a lot of us practitioners, doctors, therapists, we forget, well, what's it about? It's about caring for the patient. And you can create an avenue to care for them.
Right.
That's so
you can.
cool.
You can. Wow. Yeah, and I think that a lot of times when people get so inundated with, just the day-to-day, they can forget about, oh, wait, there is a person on the other side of this that could be my mom, my dad, my spouse, anybody. So it's really important. I always tell patients, I'm going to tell you exactly like I would tell someone in my family. And they're like, really? I'm like, yes, really. So I will. And they like that. They're like, okay, you're making it real. And so, that's
awesome.
what I would say.
That's awesome.
Yeah.
Thanks again for tuning in to watch this episode of Charlin Care Pods with Dr. Mo. There'll be another episode with a Q&A with Dr. Mo, so stay tuned. Thanks again. God bless, and we'll see you next time.